Okay, I want to thank everyone for joining us for a special webinar that is jointly sponsored by the American College of Medical Toxicology and the American Society of Addiction Medicine. This is routinely known as the Third Friday Addiction Tox Case Conference, but we wanted to bring it to a broader audience, in particular related to the treatment of substance use disorders and addiction during COVID-19. The webinar partners, again, are the American College of Medical Toxicology and the American Society of Addiction Medicine, and I want to thank both organizations for putting this together at such a time of emergency and need. I'm Tim Wiegand, the Director of Toxicology and the Toxicology Council Service at the University of Rochester Medical Center and Medical Director of Huther Doyle Outpatient Chemical Dependency Treatment Program, and I serve on the Board of Directors for both the ACMT and ASAM. We have a very distinguished panel, group of panelists and experts that I want to thank. Dr. Gloria Bishevitz, who has been a longtime moderator of the Third Friday Case Conference. She's the Medical Director of Strong Recovery and the Director of the Addiction Psychiatry Program at the University of Rochester. And Dr. Chris Bundy is Associate Medical Director of the Washington Physicians Health Program in Seattle, Washington. Dr. Paul Early is the President of the American Society of Addiction Medicine and is the President of the Federation of State Physician Health Programs, Atlanta, Georgia. Dr. Mike Holland is the Clinical Associate Professor for the Department of Emergency Medicine at the SUNY Upstate Medical Center and a Senior Medical Toxicologist for CTEH in Syracuse, New York. Joanne Lace, Dr. Lace is addiction medicine physician and colleague at Hennepin County Medical Center. Dr. Lewis Nelson is a professor and chair of emergency medicine at Rutgers University, past president of ACMT. Dr. Jean Marie Perrone, professor of emergency medicine at the University of Pennsylvania and director of the Division of Medical Toxicology and Addiction Medicine Initiatives in the Department of Emergency Medicine at the University of Pennsylvania. Myra Rodriguez is an affiliate member of the American Society of Addiction Medicine and the Director of Medical Affairs at Huther Doyle Chemical Dependency Treatment Program. And Dr. Ed Salsitz is an Associate Clinical Professor of Psychiatry at Mount Sinai School of Medicine and educator and frequent lecture clinician for ASAM and the PCSS series through the SAMHSA. So we've got a very distinguished panel. The webinar will be available for CE. If you're watching this live on WebEx, you must complete the survey at the end of this webinar in order to receive the CE. All other viewers, including YouTube live stream, must watch a recording, which will be made available in the ASAM e-learning center, and you can see the link below. We have no disclosures reported. None of the panelists have disclosures related to the content in this webinar. And I want to begin with just a few slides related to COVID emergency and the pandemic. Going back to early March, it was like a storm on the horizon that we knew that things were changing dramatically. And I recall on March 11th, sending out notification to our clinicians and patients about some changes we're making with regards to group size, safety for patients with comorbidities, asking them to stay at home, perform only individual sessions via phone with the counselors, and potentially only coming to the clinic if they needed medications for opioid use disorder. And we set some screening parameters at entry and started to do social distancing. But very early on, we were getting warnings that that's not going to be enough. An early communication from Washington State from an opiate treatment program director identified some very clear vulnerabilities, and this is just related to the opiate treatment programs. He identified that 35% of patients were homeless with high rates of comorbidities at risk for COVID transmission and serious infection. The population frequently moved throughout the community, hospitals, detox, jails, medical clinics, social services, and there were congestion points that placed patients at risk in not just the opioid treatment program, but all of the addiction treatment centers, med dispensing, urine collection. There was some site guidance that followed and principles. The American Society of Addiction Medicine had put out some very clear support through resources on their website. The principles were to protect patients, maintain access, maintain therapeutic environments, which has been challenging with regards to social distancing and risk for infection. Considerations included acuity of substance use disorder treatment needs, medical risk if COVID-19 infection, and the risk of spread as well. And this is all done in the context of federal, state, local regulations and directions, as well as resource limitations and training and staff limitations. And all of this was changing at a light speed thanks to advocacy efforts, as well as flexibility and regulations, which were critical. You can see the homemade masks that some of our staff were using. We had limitations in PPE. I want to reference the ASAM website that has excellent COVID resources, and the ACMT website also has this recurring webinar Wednesday afternoons that I'll reference at the end of this webinar with updates from the front lines as well as other information, and want to jump into the first case because that's going to be the main content. So this first case involves a colleague that has identified some drug testing results from a professional monitoring program and is requesting some feedback. This involves a 37-year-old male who has a history of opioid use disorder and is an emergency medicine physician in a busy New York hospital. His history is that he's used alcohol, cocaine, prescription opioids, and heroin in the past, and initially had gotten into trouble after a DWI episode, which served as essentially a sentinel event. At that time, his attorney had suggested that he contact the State Committee for Physician Health, or CPH in New York, and he was very candid about his substance use beyond his alcohol involved in the DWI. And in the midst of sorting out legal and professional ramifications related to this, he entered into a 5-year contract with the State Physician Health Program in New York. The physician had completed outpatient substance use disorder treatment, maintained contact with a psychiatrist on a monthly basis, had been taking naltrexone as a monthly injection after initially using buprenorphine for opioid dependence, and he had professional monitoring as well as 4-time monthly random urine screens, which were consistently negative for monitored substances, including ethyl glucuronide and ethyl sulfate. Physician's monitoring had been ongoing for 3 years as per a consent agreement to complete CPH. It was signed midway through his first year. He's practicing with full and unrestricted license and appeared to be doing well since a DWI episode in his entry into CPH. The physician is married. He has 2 young kids, regularly attended caduceus meetings during the first few years of sobriety, but this stopped as his activities with his kids have increased. In the second week of March 2020, he is told when he calls for one of his random daily screens that the clinic and provider he's been using as a drug testing monitoring is no longer directly providing screens as they've converted to support to telehealth and drug testing considered non-essential at this point. And so he's in a panic and he calls CPH wondering what the repercussions might be because he's signed into this contracted monitoring program. So my first questions are, what are the typical screening process or procedure for a state monitoring program, a committee for physicians health, for example, and what flexibility is there during a disaster emergency situation? And I'll ask Dr. Early if you can comment on this, and Dr. Bundy can follow regarding this question. Dr. Early.
Thank you, Tim. Well, this is an interesting case and has some interesting clinical points in it as well. First of all, different PHPs have different schedules for screening. They're always random, and they're always done by a check-in process or some way where the individual finds out they have a screen during a specific day. Different states have different frequencies and different tapering schedules. And there's no good research about one schedule being superior to another, although that's something that the Federation of State Physician Health Programs has a lot of interest in. So there's not a typical screening. I will say weekly screening at someone 3 years may be a little more frequent than some other states may do, but that does occur as things move forward. As far as flexibility, the Federation of State Physician Health Programs, when COVID began, surveyed its members and asked questions about frequency and flexibility in drug screening. We found that at the very outset of the COVID epidemic, with an abundance of caution, most PHPs decreased their screening somewhat. A few actually discontinued screening until it was determined whether screening sites would be safe. The other thing that occurred were in many of the screening protocols is the screening drop sites that were available. It was determined whether any of those sites were concomitantly doing testing for COVID-19. That information was sent to most participants for safety, and procedures to ensure social distancing could occur and safety at drop sites for urine screens were implemented, including things like scheduling an appointment, determining times when the fewest number of other individuals might be present at the drop site, and querying the drop site as far as whether the drop site had implemented social distancing and those sorts of things. Most PHPs are now doing some modified screening protocols, and really it basically comes down to balancing the risk of infecting someone with COVID-19 who's going for a urine drug screen versus the dangers of what might happen if not only to the participant but also to the public if an individual who has a lapse in their remission occurs in terms of public safety. So that process is ongoing, and there's a lot of intensive discussion and frequent discussions in the Federation of State Physician Health Programs to find the best balance there. One last thing I might say is that this has actually impelled many of the state programs to work to consider other types of screening protocols, individuals that PHPs that are doing less breathalyzer testing with automated video of the breathalyzer test. That is increasing in some states, as well as consideration of saliva testing with video sample confirmation. So all of those things are under discussion with many of our state programs.
Thank you. I wonder, Dr. Bundy, could you comment on your experience in Washington? And I have one question, whether there's certainly different ways a physician can enter into CPH, and whether they were simply enrolled in the physician health program or as monitored under something like the OPMC in New York or the medical board in other states. Have you found any difficulty if there were the dual points of entry in one versus the other, more stringent, or is the OPMC or equivalence allowing some flexibility? Dr. Bundy.
Yeah, that's a great question. Thank you, Tim, and thank you for your overview, Paul. I'll give a little bit more, I guess, boots on the ground specifics from Washington as kind of an example of what Paul talked about. We went virtual on from an operational standpoint. We went to virtual operations on March 9th, fairly, I guess, early on in the whole process. Within a week, all of our facilitated monitoring groups, or professionally facilitated monitoring groups around the state, were running on Zoom to help people social distance and not gather. And pretty early on, we were, concerned and making plans around what to do, or specifically around urine toxicology testing, which obviously requires you to show up at a drop site with all of the attendant issues that Paul mentioned. The reality for us was that we didn't have as many problems as we thought with the availability of testing sites. At one point, a very large third-party administrator for toxicology testing that serves many PHBs but not mine, in particular, reported out that less than 5% of collection sites were closed or unavailable, so they still had the vast majority of collection sites open and available, and we're implementing the kinds of measures to, mitigate transmission of illness at those drop sites. We took an approach sort of philosophically of this is an incredibly stressful time for healthcare professionals, and we want to find that balance again between mitigating disease transmission, both to and from the doctor, while also not sort of abandoning people's recovery support in the time when they needed it most. So we took a broad, comprehensive view. How do we make sure that our participants can attend mutual support meetings and give them access to those, and what additional access can we provide through the PHP, but also then in terms of the testing, being very clear to communicate. We had a whole communication strategy rollout for the participants to make sure that they understood that we would be flexible and that we would address their concerns on a case-by-case basis. Across the board, we decreased toxicology testing. People on 48 random observed tests per year for urine toxicology testing were immediately reduced to 36, and those on 36 were immediately reduced to 24. So in the case example here, this individual would have been on 36 per year, would have been immediately decreased to 24 per year, but we didn't inform the participants of the change in the testing paradigm. Because of the way the randomization is done on an annualized basis, you would not probably be able to detect for 6 to 8 weeks that your schedule had been decreased, because in any 1 month, you can have, if you're on 4 tests, or if you're on 48 tests per year, you would have 3 some month and 5 another. So it would take some time. And we know from our experience working with participants that the accountability of the toxicology testing is a really important part of their overall recovery process. So we wanted to make sure that we were able to address that. I think an important point that you raised, Dr. Wiegand, is that it was important for us to be in communication with our stakeholders along the way, including the Washington Medical Commission and the other disciplinary authorities with whom we work, and just provide some reassurance that we were making adjustments and that we were also attempting to be flexible in finding that balance. And I got nothing but support from the disciplinary authority. They understood the need to manage this under these circumstances. Everybody was managing something in their universe that was requiring flexibility and compromise. So I actually found it pretty easy to implement some measures that were acceptable to our various stakeholders. As this is worn on, we believe in Washington that we're past our peak in terms of the current wave, and so I feel like we've weathered it pretty well without having to make significant compromises to the sort of credibility of the advocacy that we provide, that is in some part based on our toxicology testing. And a lot of our thoughts and ideas touched on, the idea of alternative testing at home, oral fluid-based testing, using look-back testing if we needed to suspend testing. In some individuals, we were able to implement breath alcohol testing in combination with decreased frequency, or phosphatidylethanol testing as another measure to come up with alternatives to going to the urine collection site.
That's great. And when you mentioned look-back testing, I assume you're talking about hair testing, or is there other modality?
I mean, it's all look-back testing on some level, right? Depending on windows of detection. But, as alternatives, we could, suspend, for example, you could suspend urine toxicology testing, which gives you sort of more what I might call real-time data, and implement phosphatidylethanol, which looks back 2 to 4 weeks, hair, nail testing, that sort of thing.
Great, thank you. And as a follow-up, as the coronavirus pandemic has expanded in general, first, Myra Rodriguez, Dr. Rodriguez, can you maybe comment on just in general how it has affected drug testing in clinical addiction medicine? And then Dr. Bashevitz, if you could follow up after Myra Rodriguez.
Hi, yes. So in general practice, we have reduced the, initially with the pandemic started, we suspended all testing initially to reduce risk to our staff. And now we're looking at, a month out, starting to look at ways of offering urine toxicology screenings to patients, because we realize that that is an important part of the patient's recovery plan. A lot of patients like to have that monitoring, and it's part of their motivation to staying sober. So we are looking at partnering with labs around the area where they can go and drop off a sample safely, and for some patients coming into the clinic to drop off a sample as an alternative. But initially we had reduced or completely stopped all urine testing.
Thank you, Dr. Bishevitz. As the medical director of an opiate treatment program, maybe you can comment on how testing has been affected and, what the level, or are you continuing?
So testing has been decreased pretty much across the board because most people are coming in less often than they used to decrease their risk. And we did things like if people had a week of take-homes for methadone maintenance, they would then be given 2 weeks. So we went through the entire caseload of almost 500 patients and adjusted their take-homes accordingly. And in most cases, this has worked well. But of course, when people are coming in less to the clinic, it does cut down the amount of testing that is done. And we have moved to a curbside methadone maintenance pickup procedure so that people don't have to come into the clinic at all. But because we do mouth swab testing, that is easily adaptable to various types of curbside or walk-up situations. And then, of course, we can bring the patient in to the clinic to get urine if needed, but that is more rare.
I'm going to move along in this case. The physician is able to obtain a new monitor fairly quickly through a colleague at work, agreeing to serve as his monitor in the first test. With this new monitor is flagged as dilute with a urine creatinine of 18, which is pretty low. It's negative for the tested drugs, but he is notified that he has to repeat the test on the day of notification. And the physician explains, well, it's dilute because he drank an awful lot of water. He's worried about hand sanitizer. He's repeatedly using it every 3 to 4 minutes, and he's concerned that that level of exposure to the alcohol would have potentially positive effect on the biomarkers. His monitor is not familiar with this, and he calls the medical director of CPH and asks whether there's a risk for testing positive for the alcohol biomarkers with the exorbitant amount of hand sanitizing done to protect during COVID-19. And so my question to Dr. Holland is exposure to ethanol-containing hand sanitizer a risk for testing positive via alcohol directly, or any of the biomarkers that we typically look at for alcohol consumption?
So thanks, Tim. So that's a good question. And when these products first became available, readily used in the hospital in the late 2000s, first decade of this century, there was a concern, and initially they did some testing on some healthcare providers in 2008, and that 9 adults used these skin sanitizers 20 times a day, which seemed like a lot at that time, and none of them had the first morning specimens of ethyl glucuronide in the urine anywhere above 120. So it was felt that they probably didn't accumulate and that it was not really a risk. And then a few years later, they did what seemed like an extreme test then when they had 11 adults use it every 5 minutes for 10 straight hours, so 120 uses of a 62% ethanol Purell type hand sanitizer. And they did urine specimens at the end of each day, and the mean ethyl glucuronide was 542, but the range was about 0 to 2001. So, if you use a 500 nanogram per ml screening cutoff for ethyl glucuronide in the urine, then that would be some of those would be trigger positive. But what we use in our occupational medicine program is we use a 500 nanogram per ml screening cutoff for ethyl glucuronide, and then we use that same level for the confirmatory test, but we also use on the confirmatory ethyl sulfate. And both of these ethanol minor metabolites are about 0.1% of your ethanol is metabolized by those pathways. And the ethyl sulfate is a good discriminator for a number of reasons. None of the people that did that extreme 120 uses over 10 hours had any ethyl glucuronide that was, ethyl sulfate that was above 100 nanograms per ml. And so our test uses 250 on the confirmatory for ethyl sulfate. So you have to be concerned as a positive. It has to have ethyl glucuronide at 500 or above and ethyl sulfate at above 250. So that seems to be the best discriminator. And if they have both of those, I don't believe that even extreme use of hand sanitizers could cause that. And so that's what I would suggest, that to just reassure them that, this extreme use of hand sanitizers that you were seeing now probably is not going to be a risk for a false positive in the urine.
Thank you. I've got if you could stay on, I've got a couple of slides that I've taken from one of the lectures you're kindly enough to provide for the NISAM conference, and maybe you can just walk us through. This is some kinetics of ethyl glucuronide and ethyl sulfate, Dr. Holland, taken from one of your lectures. If you're still on, can walk us through this slide and the next.
Sure. So thanks. So this is the excretion of the two metabolites, ethyl glucuronide on the top graph and ethyl sulfate in the bottom, and you can see how those peak very quickly after ethanol use, but then they go down also fairly quickly. But you can see how in these are the y-axis here is kind of difficult to see, but you can see how at a day after heavy, a few days after heavy drinking, you can still see some of these metabolites in the urine, but it just depends on what cutoff you use. And the lower the cutoff you use, then the more you'll capture, but then you capture a lot of noise, like fermented fruit juices and eating sauerkraut and old bananas and things like that can cause a positive. And as you saw in this, what I mentioned before, that some of these low levels of ethyl glucuronide from extreme hand sanitizer use would be detected if you used, like, say, a 200 ethyl glucuronide cutoff. And so most programs use about 500 to 1,000 to just, to make sure that you're picking up beverage alcohol and not something extraneous. And this next slide that you just showed is the one that I mentioned, that these people, 11 adults, use Purell every 5 minutes. So that sort of mimics what people are doing nowadays with the COVID pandemic. And then you can see that the range was quite high, quite broad for the ethyl glucuronide, but none of the people had, very few of them had any ethyl sulfate at all. And the ones that did, that were all less than 100. And so I think our discriminator of 250 nanograms per ml for ethyl sulfate, which is what our program uses, suggests that that would be safe to use. And so the only thing I suggested is to the utmost of caution to just raise, instead of 500 as your positive confirmatory for ethyl glucuronide, use 1,000, and then keep the 250 for ethyl sulfate if you had that flexibility in your lab program.
All right, thank you. That's excellent. Before moving on to case 2, I want to ask Dr. Nelson is chair of the Department of Emergency Medicine. With the stress on physicians, in particular in the front lines, Dr. Nelson, Dr. Perrone are right down in essentially the epicenter in the U.S. Are you noticing higher rates of stress, particular programs monitoring just the physicians for staying healthy? Chair, you're most likely aware of the physicians in the programs. Are you reaching out with more frequency? Can you comment a little bit on what your process is, Dr. Nelson?
Thanks, Tim. It's a great question. Of course, this is something that we're very concerned about now, and the wellness and sustainability of this kind of work among the staff. I would say overall, most people have not had any consequential problems maintaining the current level of activity. We provide a lot of venues for people to seek help. Obviously, it's all confidential, but my door is always open, as are some of the other senior faculty in the department. I have not personally really seen much that would be concerning. I spend a lot of time talking to the residents, the nurses, the attendings, the technicians, and everybody else downstairs, including the environmental folks who do the cleaning. And I do think that the amount of the morale and the camaraderie and the positive vibes that we get from the community have really uplifted everybody's spirits. And everybody's working harder than usual, which on the one hand might bring a lot of mental stress and anguish, but it also seems to be very supported by the people that are around them, the patients, probably more so than any time I ever remembered in my 30-year career in medicine. People have felt really good. So now I don't know what's going to happen, as this peaks and starts to wane. But as it stands right now, I must say that I really have not seen much in the way of adverse effects. It's not been formulaic. I haven't been, assessing people directly, but certainly in a passive model, I have really not seen much.
That's great. That will be interesting to see if there's the pink cloud effect initially with the crisis as it wears off. Dr. Perrone, can maybe you comment from your experience?
Yeah, well, one thing that we wanted to do at our health system for the past year that we really haven't figured out how to do was we wanted to embrace the recovery-friendly workplace that is a movement in New Hampshire where we were thinking that we were going to start recovery meetings across our hospital and health system. And we weren't really able to get that off the ground because of location and timing. And we weren't really sure that people would take advantage of it. But we have just started a virtual meeting under that same premise to support people in recovery in the health system. And now we have this beautiful, relatively anonymous opportunity to do it virtually. So I'm eager to see how that turns out. And it's being listed as a wellness resource, across our both university and health system. So I can report back on that, but it might be a time for other people to consider that kind of approach in their hospitals.
That's interesting. I hadn't heard of the New Hampshire approach. I'll have to look into that. Dr. Salsitz, do you have any comments from Mount Sinai and your involvement in New York?
Can you hear me?
Yep.
I'm on mute. Can you hear me, Tim? Oh, I need to be unmuted.
Yep. Nope, you're on. You're live.
Okay.
Go ahead.
And I don't have anything extra to add, except I had one thought that sometimes these kind of cataclysmic events may bring out the best in people and the best maybe paradoxically in treatment. I remember during Hurricane Sandy, which was a really catastrophe in the New York City area, the methadone patients would be able to go to any methadone clinic and be guest dosed. And there was this fear that they would they would tell people they were on a higher dose than they were on. And it turned out when they looked back at all of that data that the vast majority of people provided the correct dosage that they were on, and people weren't looking for higher doses. And the other interesting item that I saw just yesterday in the New York Times, a psychiatrist wrote a letter, and she said that she's had a couple of patients who have chronic anxiety, and they've noticed that during this whole corona episode, their anxiety has decreased. And they give a couple of possibilities of why that might happen. And so I think that even people who are vulnerable to relapsing may have a sort of a paradoxical effect from this coronavirus and step up in a way that we don't expect them to be able to do.
That's great. Thank you for sharing that. That's really interesting. And this is in the, while some populations are rising up, at the same time, in New York State, I know alcohol consumption is up close to at least 40 to 50% from prior levels. But it's optimism. It's great to hear from many of the different panelists. Let's move on to case 2. We've got a couple of other cases, different types of scenarios. And the case 2 involves a 31-year-old who contacts an outpatient treatment program to receive treatment for his opiate use disorder, and it involves some challenges stabilizing via phone and telehealth contact. So some specifics include, this is the 4th week of March. The local treatment program was receiving an increasing number of calls for initiation of medications for opioid use disorder. And the process up until March 31st was to perform the direct audio-video evaluation for the initial medical encounter after an initial phone screen. After the medical evaluation, the patients were linked to the on-call providers who could follow up with another audio-video evaluation before deciding whether or not to prescribe buprenorphine or other medications if the opioid use disorder was diagnosed. And this is not in an opiate treatment program for methadone, by the way. On March 31st, the program receives guidance after the initial evaluation for prescribing can occur via phone only during the emergency, both nationally and at the state level in terms of guidance. My question is, how has this changed your practice for initiating buprenorphine? What settings are you providing this support for? Are there any exclusions to this guidance where patients are required to have either an in-person or direct audio-video encounter before the first prescribing buprenorphine? And maybe Dr. Lace can answer this first.
Can you guys hear me?
Yes.
Can you guys hear me? Okay. So
yes.
I have the luxury of working in the hospital and doing consults, so we do often get to see somebody face-to-face still. We've increasingly been doing telephone consults in the hospital too, so there's been some cases where it's worked out very well to have them interviewed via phone, and then they follow up with our clinic via phone as well. We don't actually have any visual components yet. There's a few cases of people that are chronic pain patients or sickle cell patients that we're doing a microinduction of buprenorphine on that we, in the middle of the transition off of a chronic opioid, we feel that they would be best served being seen in the clinic, and we do have opportunities for those small amount of cases to be seen physically.
Dr. Bashevitz, maybe you can comment on your experience from Strong Recovery, what the providers are doing.
Well, we have started doing induction by phone a little bit. We also have a stabilization program where people can come in, and normally they come in 5 days per week to get stabilized on buprenorphine. But what we do is decrease that amount of attendance during the COVID-19 crisis, so that we might see them a lot less. So we have a couple of options there.
Dr. Early, maybe you can comment on either your practice or guidance from ASAM related to this.
Well, ASAM, probably the best way to comment is about ASAM's position. ASAM, early on in the COVID pandemic, gathered together a group of clinicians to take a look at the transition to telemedicine, the transition to teleinduction on buprenorphine, and other related issues. And the ASAM website, the task force, which I called into being, was headed by Ingvild Olsen and Kelly Clark, and we had almost 65 contributors from across the country to develop those sections. And in there we talked about changes in telehealth and asking for changes in telehealth, which were implemented by CMS, as we all know. We talked about issues around patient safety and initiating buprenorphine. And I think that has been quite successful, and we're really proud of that. I will say for everyone on the call and everyone on the to keep checking back, because this COVID-19 section of ASAM's website continues to evolve. It's become quite complex, and more data is emerging about efficacy. And I'll stop my comments there. Thanks very much, Tim.
That's great. Myra, would you be able to comment on your experience with telehealth in the outpatient clinic?
Hi, yes. So I think the biggest change for initiating buprenorphine in the outpatient clinic has been to rely mostly on the history of the patient, and without having any objective urine results or any other types of records to review before deciding whether or not this patient is appropriate for an induction. Another change is that the follow-ups or the prescriptions have been given for a longer period of time. So previously for an induction, we would do like a 1 or 2 day, prescription just to get a feel of how the patient did with that. Now we're extending it to the initial prescription, maybe a week, hoping that we can still connect with them, in a week. I think those are the biggest challenges or changes. I do prefer video phone calls over the phone, but some patients just don't have access to a video or a reliable Wi-Fi connection, so we have to forced to just do phone calls for some patients.
That's great. Dr. Perrone, I'm aware of a couple of different programs in New York City that have set up essentially triage centers or command post centers that have communicated with local ERs that they're available to take patients bridged directly from the ED. Do you have any experience with this, or are you participating in any programs using telesupport or linking patients from the ED using telehealth with buprenorphine?
Yes. We have, an ED buprenorphine program where most of our patients come from after they start in the ED, get their first dose of buprenorphine, or just get a prescription from the ED, and then get handed off to our primary care doctors for follow-up. We found that our primary care doctors couldn't take on new patients in this setting, so we actually were able to staff a virtual clinic where the providers could refer directly to some people who are stepping up to do telephone or telehealth remotely in this process. The problem is a lot of our patients don't have phones, so we recently got a grant to be able to share some phones with patients. The other issue is that a lot of our patients aren't coming to the ED. So much like New York City, we are standing up a telephone line that will go directly from patients to perhaps, we're not quite sure who's going to staff the front line of it. We're thinking social work student volunteers, and then it would go after a little bit of triage to a recovery specialist who would work with our virtual prescribers, myself included, to do outreach to the patient versus setting them up with an appointment in a virtual clinic. But really our big issue is our patients can't do AV telehealth, and really for the most part, about half of them can do telephone telehealth, and the other half are really struggling to figure out how to get them connected temporarily to an iPad or a phone location. So that continues to be a challenge.
Yeah, that's interesting. You bring up some great points. Doing telehealth in a couple of settings, and my administrative assistant within a 2-day period was critical in her support in turning a tox clinic, which has mostly a long-term maintenance, stable patients on buprenorphine, from completely in person to all audio video, and it really went well, but it required a lot of work on the back end, converting ambulatory visits into telehealth encounters. And I want to reference, there's a webinar on the ACMT website where we discuss telehealth in the time of COVID, and ASAM has also some webinars related to that for additional information. So let's continue with the case. This patient reports he's very happy to have contacted someone that can help him. And he says, I've had to do some things I'm not very proud of to get enough money to support my habit. I'm terrified of going out. I smoke, I have asthma. Last year, I had that endocarditis thing with my heart. I don't want to get COVID and die. He reports using 2 bundles of heroin a day and about a bundle of cocaine. He uses marijuana, doesn't consider that a drug. Gabapentin, and he says, I stopped that after I've isolated here at home. He was getting gabapentin illicitly. Last use of heroin was earlier that day, 6 hours prior to call, not currently in withdrawal. And so just in general, how would you proceed with an initiation of buprenorphine in this patient via phone? And I'll let Dr. Salsitz answer that. Dr. Salsitz. Let's see if we can unmute Dr. Salsitz.
Hello? Does this Tim, before I answer, does this person in this scenario have any significant others who may be able to help and provide support and oversight, or is the person all alone?
That's a great question. He has 2 kids not currently with him, and he has a significant other or ex that are not with him at his apartment. So he's alone at his apartment. Apparently has some people he can reach out to. Not clear really how supportive they potentially would be, but it would be via phone.
Well,
he does have some experience with buprenorphine.
He does have some experience, so he understands about the induction, precipitated withdrawal. I guess I would provide a small amount of buprenorphine tablets or film strips, educate him on how to do the induction, ask him to be in mild withdrawal. He's not in withdrawal now, and then begin with 2 milligrams. I still begin with 2 milligrams, and I generally use the 8 milligram formulations and cut them. I don't usually do 2 separate formulations, and if he knows a little bit about buprenorphine, he's done it before, I would outline how to do it again and ask him to start and be in touch with me when he begins.
Very good. After a full phone interview, the patient has 8/2 milligram buprenorphine naloxone films prescribed to the local pharmacy, along with clonidine 0.1 milligram tabs, with instructions to take a quarter of the 8 milligram film the following morning when he feels at least moderate withdrawal, anorexia, anxiety, sweating. He's been on buprenorphine in the past, although it's been years since it's been prescribed, and some street experience. And the clonidine instructions are 0.1 every to take Q 6 hours as needed, and about 30 minutes prior to the first dose of buprenorphine. After 1 hour taking the 2, he can take 8 and then continue at 8 twice a day. And a telehealth encounter is set for 3 days later. It's a Tuesday for an observed dose instruction via Zoom, given that Friday the first encounter is just via phone. So on the follow-up call, he answers a Zoom invite but reports, so I took both doses this morning. I don't have it with me now. And he says, well, I have to go to my sister's, and I can't call back later. I can do it Monday, no problem. So it's set up, again, well, it's not set up for Monday because the regular follow-up was set up for Tuesday, so it's set up. And the following Tuesday, he is supposed to be doing an observed dose. The 10-day prescription had been sent initially, although there's a 7-day follow-up made after the observed dose. And so my question is, and we've kind of discussed this initially, how has prescribing changed for outpatient buprenorphine during COVID-19 or in general during any emergency? Maybe Dr. Perrone, maybe you can comment on bridge prescriptions out of the ED or in your clinicians.
Yeah, we've asked our emergency physicians to extend their bridge prescriptions up to 14 days as needed. They're usually making these appointments or these initiating buprenorphine for patients who are going to follow up, with us, but they're usually in contact with the recovery specialist who can gauge how long the patient needs in the first prescription. But my colleagues have been very willing to write for longer prescriptions so that we don't have to worry about immediate bridging. Or, you even have to think about the patients going back and forth to the pharmacy, on a weekly basis versus, every 2 weeks. It really decreases their exposure if we can provide for longer periods at a time.
That's great. Dr. Bundy, can you comment on your experience and practice in Washington?
Hi, I just have to unmute myself. Well, this isn't really. I'm full time with the physician health program, and so I don't have. I've been doing that for the last 6 years, so I really haven't had a tremendous amount of experience in this particular area.
Dr. Lace, what about from Hennepin?
We have gone to longer prescriptions as well. since we don't have the visual component, I think the follow-up of the observed dosing isn't being used. And we've also done this with the methadone program as well. People that were on 6 days a week are now on 2 days a week or 3 days a week, and we thought there'd be an increase in methadone overdoses, and we haven't really been seeing that. And I think since buprenorphine has another factor of safety, I'm very comfortable with having the longer prescriptions.
That's great. Thank you. Dr. Nelson, at Rutgers, I know that buprenorphine is prescribed from the ED and other settings. What has your experience been?
It's not all that much different than the others, with two, perhaps minor differences. In the ED, we're very willing to do induction at a fairly aggressive pace so that people don't have to really follow up and get their induction. They can certainly get a prescription from the ED. We don't typically need to give longer prescriptions because our follow-up has been fairly easy to obtain. We've, like others have done, telehealth or phone calls. But one of the things we've been pushing to do now is we actually are trying to set up a WOW, a workstation on wheels in one of the areas of the ED, so that for patients who don't have their own video links, they can come in and use ours and connect directly up. And it's easy enough, it's essentially an iPad on a stand that can be disinfected pretty easily after it's used. And it makes it easy for people to find a central point to come in and do their video interviews.
That's great. Thank you. And continue with the case. The following Tuesday, 7 days after the initial encounter, the patient-provider successfully is connected with a counselor twice, and notes suggest he really appreciates the contact. Nicotine replacement was sent as well, and he reports motivation to quit smoking due to concern about his lungs. During the Zoom encounter, the patient takes a film and then asks if he will be able to pick up the prescription that day. As a reminder, it was for 10 days, probably would be about 1 to 2 days yet. Some of the pharmacies are allowing a little bit early pickup. About an hour after this call, his counselor notifies the provider this patient is blowing up his phone with messages about needing more medication. He said he took all his subs to treat gabapentin withdrawal and didn't want to say anything because he thought he'd get in trouble. So he's asking her to ask the provider to send another prescription so he doesn't go into withdrawal. So I'm wondering what the options are and how you would proceed with this. Dr. Bashevitz, maybe you can comment. Or if Dr. Bashevitz, you're struggling to get off. There you go.
Oh, I'm sorry. Yep, I'm okay now. So that's raised things to a totally different level with the thought that he's taking subs to treat gabapentin withdrawal. Frankly, I've seen a lot of people who love gabapentin, but I've never seen anybody who says that they use buprenorphine to treat gabapentin withdrawal. I mean, I don't say it doesn't happen, but I would suspect he's just sold them maybe to buy heroin or something of that nature. I would wonder about the veracity of that comment. So at this point, I would feel a little bit uncomfortable about this whole thing and want to call him in for an actual visit, if that's possible, in the given facility, or whatever is possible. Maybe he needs a higher level of care. Maybe there's an inpatient setting, or maybe a detox setting available in that area.
Very good. Since there was an observed dose that day and a very full schedule, the provider calls back the following day several times, and there's no answer. At the end of the day, he receives a text from the counselor that the patient is again calling, asking for the prescription. After communication with the counselor directly, she calls back and arranges a phone contact. And the patient says, I didn't want to talk about the gabapentin or say anything but buprenorphine because I didn't think I'd get another prescription. He says, I'll do another observed dose. And a detailed interview now follows with much more information about, what is his history, what information support. And he reports he's been using a lot of gabapentin. That suddenly stopping the gabapentin caused withdrawal, but he says, I'm okay now. no further gabapentin, no cocaine. I haven't been out of my apartment since picking up the prescription. And yes, this buprenorphine didn't really help the withdrawal anyway. And it was suggested that we look at a detox facility potentially, or bringing in to see directly to do this. And so my question is, if outpatient clinics, or if you're in an outpatient clinic, are there patients you're bringing in to see directly, or limiting strictly to off-site telehealth support? We've already answered that in a sense that some are. I'm going to skip ahead to the next slide. Another prescription is sent for 7 days with instructions to continue taking it at twice a day. Valproic acid is offered for the gabapentin withdrawal, and patient agrees to try this medication. No other meds, no primary care physician are available for him. And topiramate has been prescribed for cocaine craving, off-label use of this medication, but the patient hadn't started taking it. And after a pleasant discussion regarding medications for the patient's treatment, he suddenly states, okay, here it is. I just couldn't get back on the subs. I couldn't get enough time to start before using it. I ended up trying the quarter piece, but it made me sick, so I used heroin. Apparently traded the rest for heroin cocaine. Other than the observed doses, all the encounters have been via phone. And so now, what are the options for starting buprenorphine in this patient? And I think Dr. Bashevitz said it on the mark that he just needs a higher level of care, as well as Dr. Salsitz. This gentleman needs some hand-holding getting on to buprenorphine, either a detox or directly bringing in. And my question to the panel is, how available are local regional detox facilities or inpatient services or hospital-based support for withdrawal outside of just generally the ED in your area during COVID-19? And how has it changed as the emergency has progressed? And I'll ask maybe for some very brief comments. Dr. Salsitz, if you could maybe give a brief comment.
Yes. So in my particular hospital, our inpatient detox unit is still open. However, the census has been cut down to a half of what it was, so that everybody can be isolated. We test everybody for COVID with a nasal swab when they come in, and keep them isolated until the test comes back negative, and if it's positive, they're transferred to medicine. However, the availability of beds is down by a half, and our inpatient rehab, where many people would go following the detox protocol, has been closed temporarily because of the need for COVID beds. I understand that in the New York area, the counselors are having difficulty placing people in rehabs or long-term residential programs because they have also either closed or cut down on their census to be able to provide physical distancing, social distancing.
Yeah, that's been my experience as well. And this gentleman declines the bed at a local detox that is still admitting patients, although they've had to reduce their room availability by at least a third because of the switching to single rooms. He's not working, just wants to be there for his sons if they need me. So it actually, in ending this case, he's brought in to do an on-site observed dose. So he's able to do it in front of staff as an emergency induction. And we've already discussed some of the other questions. I want to jump ahead to the final case. This patient misses his observed dose in coming in and is not answering calls, and so is in the process of trying to re-engage as well. One of the challenges, I think, with initially doing the telehealth, but we've had a lot of success with them as well. Microinduction was mentioned. These slides are available. I want to jump into the third case just to briefly discuss, because this covers a very important topic that expands support in a novel way. A detox facility was not able to admit a patient due to fever, cough, and presumed COVID positivity. He's quarantined at a local hotel supported by county resources, and a Department of Health representative is called to ask if ambulatory detox for alcohol dependents could be arranged from an outpatient clinic to the hotel supporting him. The patient is a 47-year-old male with a history of alcohol use disorder. He was recently laid off, had escalated drinking, and as soon as he started to get up during the day, he started drinking. This has caused a lot of discord with his significant other and son, age 19. An altercation ensues. Police were called. He told police he wasn't feeling well and he had a fever, and they brought him into the ED. He's got a fever. He's diaphoretic. He's given some benzodiazepines for some what's presumed mild withdrawal, but he's somewhat ill-appearing, and he is starting to feel better, but he's tested for COVID. And the county program is a hotel available, so he's quarantined there while waiting for test results. And this is when the Department of Health calls for potential options and medication while he's at the hotel. So my question is, what treatment options are available to remotely treat alcohol withdrawal in this setting? Would an ambulatory detox protocol apply to this scenario? I know we have some panelists that have participated in the ASAM guidelines regarding alcohol withdrawal. Dr. Early, could you comment on potentially some options for alcohol withdrawal management in this scenario?
I can. So the first thing to know is in cases like this is frequent observation is absolutely essential. And I don't know in this case, he has a significant other and a son. I don't know about the status of their supporting this individual in a case like this. So that's the first thing to determine, I think. That's a big deal. I do know there are in some states is availability of fairly limited beds for detoxification that are distinct from medical surgical sites, which has a little bit better help. Also, the protocol for residential care with a ASAM level 3.7, ASAM criteria level 3.7 WM or 3.7 WM would be some of those places have very adequate COVID protection, and I would probably search for that type of a facility for such an individual. The biggest concern in this is is his danger. The only way I would do an ambulatory detoxification in a patient like this is if I had support of a family who was willing to stay engaged with me quite frequently. And it sounds like there's enough discord in the home that may not work. If that may not work, then I would look to find an ASAM level 3.7 program that's not affiliated with, that has all of the protective measures in place and encourage this gentleman to get to appropriate detox. Everyone has a different level of comfort with alcohol withdrawal. Over 30 years of doing this, I've had some cases that are whoppers that make me older and wiser, and I would be cautious about that, doing that ambulatory. I would spend a considerable amount of time with the significant other, and even the 19-year-old, get at least a verbal contract that they are going to remain with this gentleman 24 hours a day, that they're going to observe him through the night in order to continue ambulatory detox. Certainly using longer-acting benzodiazepines will help. Using some of the anticonvulsant detox to add in the detoxification would help as well.
Thank you. And I understand that you have to get off. We initially planned for 1 hour. We are going to continue for another 10 to 15 minutes. Some of the panelists have to leave, but we've got a couple of other scenarios that I think are very interesting and pertinent, certainly, to get out, and some excellent advice. So this patient has had 2 previous detoxification episodes with links to ongoing treatment. Briefly tried naltrexone, but after resuming drinking, he stopped taking it. He thought that he couldn't take it while drinking. He's not taking any medications, no recent hospitalizations other than the recent one where he tested positive for COVID-19. And he states that he's motivated to get back on track, to stop the alcohol use, get back with my girl and son. And the ED, his alcohol level was 90. His chemistry was normal. His transaminases were only mildly elevated. Urine screen is negative for basic drugs of abuse. He doesn't drink anything but beer, drinks 4 to 5 to 6 of the higher alcohol concentration natty daddies, no seizures, no previous hallucinations. And he is going to he is improving in the emergency department and sent to the hotel with minimal symptoms when the call came from the Department of Health worker from the hotel. So I'm wondering, a couple of the panelists have had to leave, but we've still got Dr. Holland. Would you be comfortable treating this gentleman with support in the hotel via different mechanisms? The ability to monitor him includes check-in several times a day with a county health worker, and the ability to certainly resend him back to the hospital or the emergency department. Dr. Holland, maybe Dr. Salsitz, could you comment on whether you'd be comfortable treating?
Yes.
Okay. Go ahead,
Yes.
Mike.
Can you hear me?
Yes.
Can you hear me? Yes. No, I would be comfortable for a few reasons. Number one, you include in the history that he has no history of seizures, no previous hallucinations, and some alcohol withdrawal syndromes are relatively mild. It would be nice if somehow there had been a CEWA done so that we had a way to gauge the severity. But I think that front loading with the diazepam and maybe one more dose of a long-acting benzodiazepine, and I personally would use gabapentin here, both as a treatment for withdrawal and as an early maintenance medication to try to decrease the amount of heavy drinking. So with somebody in the hotel being able to monitor, being able to call me, I would be comfortable going ahead with the detox protocol.
That's great. Dr. Holland, I think you had unmuted. We're going to answer as well. What would your thoughts be? Dr. Holland? Oh, Dr. Bishevitz, what about, would you be comfortable treating this patient in this setting?
Well, basically no. Though if you started with, if you used gabapentin, that would be certainly less dangerous. But I would try and find a facility where he could go to, just because of being unfamiliar with capabilities of county health workers and not having any kind of family who's watching him. I imagine that if he's put in a hotel, he can still come and go as he pleases. And it just sounds like something that I would be uncomfortable with. And I do know that some of the rehabs can initiate detox in this area and have a sort of isolation setup going. So it could be possible to get some sort of situation like that.
Great, thank you. In this case, he was kept at the facility, and the patient was given a single dose of 10 milligram diazepam to take on the first day, dropped off by the health worker. And then gabapentin was utilized as a protocol that we've used in the hospital, more of a prophylaxis, but also that does treat mild to moderate withdrawal at 600 milligrams QID for 5 days, along with some clonidine. And I think that's a pretty safe protocol. Encounters were performed directly via telehealth, phone, and it turned out the provider had previous encounters with this gentleman in the detox facility, so it actually was somewhat familiar. Naltrexone was ordered to start on the 5th day after the gabapentin, and which was increased to 900 3 times a day after day 5, and the patient is doing well. The initial 10 milligram dose of diazepam and ED helped quite a bit, so a more mild form of withdrawal, but I think a fairly safe protocol. There are some guidelines on ambulatory and other withdrawal management sites from ASAM that have been made available, in particular related to the COVID emergency, and it's available on the website. Several of the experts, Dr. Nelson, Dr. Early, have been involved in preparation of these guidelines or review, and this is an excellent resource. There are some sections related to protocols for the ambulatory setting, and I know in our area in Rochester, there's an increase in the use in particular because some of the detoxification and inpatient beds were associated with hospitals that are potentially using them for COVID. And so the thought was that this would need to be an increasing type of withdrawal management, and certainly level of comfort as well as need are going to guide whether or not this is used. Benzodiazepines are the first line, but gabapentin and adjunctive anticonvulsants can be used as well. Our final case involves a 44-year-old patient with a long history of opioid and stimulant use disorder that has taken several doses of his 2-week take-home quantity of methadone when he received extended take-homes, which he normally attends 6 to 7 days of the week. He's given naloxone by his partner as he becomes unresponsive, and he's transported to the emergency department. He initially responded to the intranasal naloxone, but he's now becoming more somnolent and is nearly obtunded by the time he arrives to the emergency department. His significant other thinks he took 3 of his 75 milligram bottles about an hour or 2 before she gave him the naloxone. She reports he also uses some street Xanax bars. The patient is moved to the critical care bay, has a respiratory rate of 6, marked meiosis, some evidence of vomitus around his face, chin closed, stigmata of IV drug use. With support, his oxygen improves with bag valve mask and 100% of FiO2. And my questions are, what are your options for treating this patient with presumed methadone overdose in the ED setting? And I think we've lost our Dr. Nelson and Dr. Perrone, but Dr. Lace, could you comment on what you would do for this overdose? At least he's gotten a couple of doses of naloxone now.
I think that I would probably start an naloxone infusion on him and bring him into the hospital for further observation. In Minnesota, we don't have a high rate of hospitalizations yet for COVID, so we have some capacity in our hospitals to take these patients in still.
Thank you. Certainly this is going to be a long-acting opioid with something that's not going to clear after the initial dose of naloxone. So he's given very small doses of naloxone incrementally titrated to effect as one of the residents gently wakes him up to the endpoint where he's awake but not in precipitated withdrawal. But he's a little sedated after this still and mumbling, "Don't take my man." He's not agitated though. And a naloxone infusion is started at 0.6 milligrams an hour after a test dose of flumazenil is given, a very small dose, 0.05 milligrams twice with good response to confirm that he has, yes, another benzodiazepine there as well. And he reports that now when he's more clear that he took about 3 or 4 of his methadone doses and maybe some heroin, and he's admitted to the ICU for monitoring on the naloxone infusion, resting comfortably. His girlfriend states, though, that he only has 3 bottles left. He's going to be shit out of luck, right? He has 11 days before he can follow up again with the clinic. And so my questions are for how are opiate treatment programs working with patients that run out or overuse or are otherwise missing their methadone before it's due during COVID-19? Maybe Dr. Bishevitz can answer and then Dr. Salsitz.
Okay, so can you hear me?
Yep.
Yes.
All right. So in this case, this is a little bit different because this person is already in the hospital, in the ICU, and you are going to stabilize him in the ICU, and he will end up on a stable dose of methadone that we can in fact prove what he got because we could look at the hospital record for what he got. Therefore, we can continue that. He won't be out of luck in any way once he follows through with the methadone clinic. There are other times where people sometimes can be out of luck if they, for example, leave a month's supply on the bus or something like that. That's different. But yeah, we do try to be a little more understanding during the COVID-19.
And Dr. Salsitz, I'm going to ask one other question. Maybe you can comment overall. Some opiate treatment program directors and others have suggested methadone be available through office-based prescribing or even in a pharmacy like in Canada during this emergency. And I know you have experience with the medical methadone maintenance model. And I'm wondering what your thoughts are in this case and then on if the medical model would be appropriate in the COVID emergency.
Well, I do have a lot of experience. For 35 years, we were not prescribing, but we were dispensing methadone in an office-based setting. The methadone was coming from the hospital pharmacy. However, that would have been a very, very difficult problem for me had I not discontinued the program in January, because it would have required people to come in, and that's become a very, very big problem. I think the only way this can work is more on the buprenorphine model, where we would be able to prescribe methadone and people could pick it up in the pharmacy. You're right that the Canadian model is to use the pharmacies much more, but our culture here seems a little bit, different. I can't see people walking into a crowded CVS or Rite Aid and the pharmacy giving an observed dose of methadone and giving a person some methadone. But I think that this case, Tim, is a good case because this is the risk-benefit ratio of trying to help with the COVID versus giving people doses of methadone that are potentially lethal. But in this case, like in many cases, it's hard to say what the contribution of the alprazolam was versus the methadone itself. The only other thing I wanted to say, just a little medical on this case, is probably an EKG is a good idea in terms of the QT interval. And I was a little worried about that vomitus around the mouth and whether he might have an aspiration pneumonia. But I'd like to ask Gloria, because I don't work in methadone clinics. I would assume that you're going to have to say we have to give this patient more methadone after he leaves the hospital, and not give him as much as we used to, but bring him in and make up for those doses that he has lost.
Bring him in to come and get his doses. Yeah, that's true. We probably would say that we would bring him in more often, but our situation is a little different from yours in New York City, where we have our curbside dispensing set up. So it's a very almost risk-free thing where he can get the methadone by sitting right in his car.
Gloria, I wasn't even talking about the COVID angle. I was just saying that I think it's a good idea to give people more take-homes because of the whole COVID situation, but there is a risk, and when it doesn't work well, the methadone supply will have to be replaced.
You mean he'll have to come in extra for dispensing? Sure.
If he's off that many bottles, he's got 3 bottles left, and he's got 11 days before he's supposed to come back. So the experiment and the harm reduction didn't work that well in this case, and you're going to have to somehow make up the methadone.
No, and we've certainly done things like that. We have extended people's take-homes from, and given people a week's supply when they're not used to it, and most people have done remarkably well, but there have been a few people who we've had to decrease their take-homes. Yep.
That's great. We had a good comment I want to read from Dr. Rasimis, who mentions in this case it's important to understand why this patient used methadone in excess. Is it his addiction, or is it something else in depression, suicidality? He needs to see psychiatry if it isn't easy to sort out what actually happened here. That will define partly what happens next, and I agree with that. And this patient is given the option of buprenorphine microinduction as he receives the naloxone drip, and he agrees because he says that that's probably the better option. If I get more than one take-home, this might happen again. He comments that the methadone is working fine for his girlfriend, but she's doing better saving than I can do. And buprenorphine microinduction is started as the naloxone infusion is completed using 150 micrograms of buprenorphine sublingual. The methadone is still in his system every 4 hours times 4, or every 6 hours times 4, followed by 450 micrograms. I should say micrograms, sublingual, not milligram, every 6 hours times 4, and then 1 milligram, 2 milligram, and 4 milligrams. Over a 4 or 5 day period, the buprenorphine is slowly added on top. Methadone was restarted on day 2 as he had some withdrawal at a lower dose, 40 milligrams split, and that's only continued for 2 days, decreased to 10 milligrams. So the methadone is titrated down as the buprenorphine is titrated up, and ultimately stabilizes on 8 milligrams of buprenorphine and naloxone 3 times a day, along with some clonidine and topiramate, as he was also using cocaine. He complained of mild benzodiazepine withdrawal symptoms on day 3, about 24 hours after the naloxone was off, and phenobarbital is administered using a 3-day titration protocol adjunctive to the other treatments, which involves 129.6 or the 130 milligram doses every 4 hours for 6 doses, every next day 6 hours and 4 doses, and the third day every 8 hours times 3 doses. And he tolerates this fine and without any withdrawal, and is able to be discharged with follow-up on buprenorphine in coordination with the opiate treatment program. And the last slide, I just wanted to show the methadone medical maintenance model. This is a paper from Dr. Salsitz, who published on his experience of methadone medical maintenance treating chronic opioid dependence. And the suggestion has been to potentially decongest the clinics in areas that are particularly hard hit by the COVID to allow office-based prescribing. But there was criteria for the patients that qualified for this. I believe they were very stable. They weren't the early patients. They were meant to meet certain criteria. Maybe Dr. Salsitz, you can describe what criteria your medical.
Yeah, they were very
patients.
strict criteria. Patients had to have at least 4 years of traditional methadone maintenance treatment. The urines had to be negative for all illicit, non-prescribed medications for the past 3 years, and they had to be using their time productively, which meant either work or school or retirement or being a caregiver. And we had excellent results. We had 347 patients total enrolled, and we never had one overdose death or anything related to drug misuse. But again, they were a very carefully selected group of people who had done well. We thought we could ease up on some of the criteria rather than, 4 or 5 years in a clinic. It could be much less. It's a very viable option, but it needs prescribing, not dispensing.
That's great. Thank you. And then we come to the end of the case discussion, and if we've got a couple of minutes, if there's any questions from the audience. We had a question early on if the slides and resources be shared, and yes, they will be available through a link on both the ASAM and ACMT websites, and recordings can be watched as well. A copy of the slides are available. Dr. Dye had a question if any of the panelists have physicians in recovery that they know of, and how are they doing. It is unlikely that they would know someone that's not doing well until things get really bad. And I think that's pertinent. If is Dr. Bundy still on the line? I think he may have left. Dr. Salsitz, Dr. Early has also jumped off. Dr. Bashevitz, maybe you can answer that. If you're working with any physicians in recovery, if you have any knowledge on how they're doing. Dr. Nelson, I think had commented a little bit about this earlier.
No, I'm not working with any right now, and so I don't know how they would be doing.
Okay. We had a couple of comments on the ambulatory detox option, and several attendees agreeing with supporting using the gabapentin and monitoring. And I don't see any other comments or questions. Our contact information is available. If anyone has questions or comments, please reach out to myself. I want to also announce ongoing webinars, the Medical and Public Health Considerations of COVID-19, a regular Wednesday webinar at 3 p.m. The next one is April 22nd, jointly sponsored by multiple toxicology, poison control, emergency medicine organizations. And the next webinar is updates from the front lines on Florida and India, as well as research highlights on remdesivir, hydroxychloroquine, and chloroquine. And the next third Friday Addiction Case Conference will be in May, and hopefully we'll be able to put together another panel of experts. And want to thank everyone for attending and participating. We also have a town hall and Q&A on practical issues of PPE and COVID-19 on Friday, April 24th at 12 p.m. You can register at acmt.net COVID-19 web HTML. Just go to the ACMT website if interested in registering for the town hall. And again, thank you all for attending, and good luck and stay healthy.